Hello, I'm Dr. Tedesco D.O, Co-Associate Program Director for Good Samaritan Regional Medical Center's Orthopedic Surgery Residency in Corvallis, Oregon. Today I'll be lecturing on the topic of musculoskeletal oncology, radiology basics, as part of our ongoing lectures online to supplement our in-classroom case-based learning. My disclosures are up to date and public at the AAOS website. In addition to those disclosures, I have a large disclosure to make regarding this presentation, similar to my histology basics lecture. The idea for this presentation came from many resident requests to find a way to show them exactly how I work through x-rays, CTs, and an MRI to reach a differential or definitive diagnosis. This is my best attempt at the algorithms I've developed in my head over the years to ping pong around and come up with a reasonable guess at the radiologic diagnosis. This doesn't go over CT specifically because CT is essentially a glorified x-ray that makes the x-ray findings more obvious and clear. This is in no way, shape, or form definitive, absolute, or anything you would ever be responsible for knowing on a standardized test. Rather, this is a tool used to help you with radiology when you don't even know where to begin. You'll notice some pathologies fall into multiple algorithms, and it assumes the quote-unquote classic pathologic appearance of the different musculoskeletal tumors when they show up on imaging. Obviously, real life is much more complex than this, so you could use the algorithm properly and still come up with the wrong diagnosis. Again, this is not meant to be definitive, but instead another tool in the box to help you out on a test of this knowledge. Additionally, there's no clinical or histologic cases given that would normally very much help nail the diagnosis. Instead, this is just a pure abstract look at radiology. The best way to use this presentation will be to copy the algorithms in your own hands and words, and then use them to guide you as you go through question banks or review radiology so you can get used to using them and see where you might be going wrong in what you're looking at. Finally, the last caveat is that this presentation does not go over specific definitions or findings. It assumes you already know and can identify things like popcorn calcification, arcs and rings, corticomedullary continuity, soap bubble appearance, and many other things. If you are unsure of any of these, you will need to reference my other orthopedic oncology lectures where we cover specific pathologies to learn these particular terms and to get used to recognizing them. So without further ado, we will get to the algorithms and then several case examples for how to work through them to arrive at a diagnosis. We'll begin with a quick review of pertinent facts and findings when you're looking at this imaging. On X-ray, you need to remember Enneking's 4 questions. Is there presence of matrix, fibrous, bony, or cartilaginous? What's the lesion doing to the bone, lytic, blastic, or mixed? What is the bone doing to the lesion? Is there a periosteal reaction or new bone formation? What is the location of the lesion? Diaphyseal, metaphyseal, epiphyseal, and additional location things that matter are, is it axial or appendicular? Is it eccentric or central within the medullary canal? Does it cross the physis or the physeal scar if it's an adult? Is it extraosseous or parosteal, meaning stuck to the surface of a bone? Is there corticomedullary continuity with the lesion in the bone? And the age of the patient also matters for the differential diagnosis, whether or not it's a child, a young adult, or an older adult. On MRI, you need to have an adequate T1, T2 stir imaging and a T1 fat-suppressed pre- and post-contrast imaging in all planes to have an appropriate tumor protocol MRI. T1, you have to look at the TR and TE ratios of how the magnet is spun, and usually that ratio for a true T1 is going to be several hundred over several tens, meaning like 550 over 25 or something like that. On a T2, the TR to TE ratio are thousands over hundreds, usually like 3,000 over 150 or something like that. When you have a TR in the T1 range and a TE in the T2 range or vice versa, that's where you get into the balanced weight sequences, something like a proton density, good for looking at a joint and at cartilage, but not good for looking at tumors. Contrast enhances live and active tissue, so it's not specific to tumor. Inflammation, trauma, tumors, reaction, edema will all enhance with contrast. T1 is best for determining whether there is marrow replacement, such as a tumor in the bone, as opposed to edema from a reaction or infection, or red marrow conversion seen in hypoxia or extreme obesity, which, much like in Pickwickian syndrome, leads to hypoxia and hypoventilation. Balanced weight sequences, proton density flares, basically your alphabet soup, are usually not diagnostically helpful for tumors. They can be helpful in terms of seeing where the tumor is located and what anatomy is involved, but it will not be helpful diagnostically to give an answer to what is the tumor. The descriptors on MRI are hyperintense versus hypointense, and that's always compared to skeletal muscle. So hyperintense doesn't necessarily mean white, it just means that it's brighter than skeletal muscle. If it's bright on T1, it's usually fat, hemorrhage, exudate, or thick proteinaceous fluid like pus, or contrast medium is always bright on T1 compared to skeletal muscle. On T2, fat, fluid, transudate, and edema are all bright. Most T2s that you see are fat saturated, which is why the fat becomes dark, because it gets very difficult to see where's fluid and where's fat if you don't saturate the fat out. If it's dark on T1 and T2, usually meaning jet black or close to it, it's usually calcium, like the cortex of bone, dense fibrous tissue like ligaments and tendons, or hemosiderin deposition. Beware of motion and metal artifact because this can change how things look on the T1 and T2 sequencing and create a lot of visual artifact and vacuum phenomenon around these things. So it can really screw with your imaging. So now we'll get to the algorithms. And first we'll start off with X-ray and we'll focus on soft tissue here. Again, you always want to start with an X-ray for any mass, even if we're talking about soft tissue, because it can be helpful diagnostically and again, in terms of what anatomy is involved or if the bone is being involved. So if you see something on X-ray, the first thing we want to look for is what does it look like compared to fat? Is it dark, meaning similar to fat appearance on the X-ray, or is it an intermediate gray similar to muscle? The next thing we're going to look at is whether or not there's the presence of a periosteal reaction, and is it mature or immature or no periosteal reaction at all. The next thing we want to look at is the presence of calcium within the lesion. Is there calcium deposition, and if so, what does that look like? Is it cloud-like? Is it arcs and rings? Is it minimal? Is it extensive? Things like that. Sometimes we do need to know the location of this. So for instance, is it located in a bursa or is it somewhere else? And you'll notice here when you start to look at some of the diagnoses, they're not very specific. So soft tissue sarcoma, obviously there can be any number of different types of soft tissue sarcomas, but if you have some of these findings, it leads you down the pathway to saying, hey, this is something ugly and possibly a soft tissue sarcoma. But you do need further investigation than just the imaging to get the diagnosis. The next one we'll look at is X-rays inside bone. And so we'll parse this out to lytic, blastic, or both. And that's how we'll start off with the bone X-rays. So once it's lytic, we need to know the location. Is it diaphyseal or metaphyseal or an epiphyseal? The next thing we want to know are things like age, whether or not there's a sharp zone of transition or is it a wide zone of transition, things like that. We again want to know the location within the bone, not just diaphyseal, metaphyseal, or epiphyseal, but does it cross the physis? Is it near the physis? What does it do there? We also want to know the size of it and what it's doing to the bone. So again, we're starting to answer Enneking's 4 questions throughout these algorithms. When it comes to the blastic things, the first thing we want to look at is where is this tumor located? Is it inside the bone or outside the bone? And is there just frank destruction of the bone? Again, we want to know diaphyseal, metaphyseal, or epiphyseal. We want to know a little bit about the zone of transition. We want to know about the calcification that's within the lesion that's making it blastic. And all of those things are going to help us come up with a diagnosis. When we have a mixed lytic and blastic lesion, similar to the blastic ones, we want to know, is there frank cortical destruction, is there cortical expansion, or is the cortex totally uninvolved with this? Then again, we want to know a little bit more about the calcium that we're seeing in there that's leading to the mixed lesion, and that's going to help us sort of come up with an answer. Then we're going to get to the MRI, and we'll talk about soft tissue and bone. So we'll start with soft tissue, and the first thing you want to know is, are there discrete borders to the main tumor, not to the reactive zone around the tumor? And you're going to see the second step when there's discrete borders is how do we characterize that reactive zone. But we want to know the tumor itself. Are there discrete borders? Are there feathery and infiltrative borders? Or are there infiltrative with no clear borders? So you can't even tell exactly where the tumor starts and stops. Then again, we want to know a little bit about the location, if it's deep or superficial to the investing muscular fascia, We want to know what the enhancement pattern is. We want to know a couple other things about this intensity on the various sequences, and that's how we're going to come up with a differential diagnosis. You can see again here, we get to sort of a differential diagnosis for many of these, but we don't get to an actual diagnosis. That's where pathology comes in, where you will need a tissue sample to prove which one of these things it is. When we get to the bone MRIs, we want to know, as we talked about before, look at that T1 and see, is there marrow replacement or is the bone marrow preserved within the lesion? If it's preserved or replaced, we go in very different directions. Again, we want to know, is it infiltrative throughout the marrow? Is it discrete? Is there a border to it? No border? Is it intramedullary? Is it extraosseous? We want to know a little bit about the growth pattern, whether it's lobular or serpiginous. We want to know what kind of change we do see on the T1s within that marrow. We want to know, is there a soft tissue mass associated with it? And if so, where? And all of those things, again, are going to ping pong us around, and we're going to end up down this algorithm to a diagnosis or a differential diagnosis. So now we're going to get to the cases where we walk through each of these algorithms to try and come up with an answer in terms of how we use this algorithm to get a diagnosis or a differential diagnosis. So the first case here is an X-ray of a soft tissue mass. And so we can see that with the arrow sign on the X-ray where there's a discrete mass there surrounding the ulna in the forearm of this patient. So we're going to go to the X-ray soft tissue algorithm and try and figure out what we've got. So the first question we have to ask is this lesion dark and similar to fat, or is it intermediate and similar to skeletal muscle? So as we look back at it, you can see the skeletal muscle goes around this thing, and then it's dark, very much like the subcutaneous fat in the forearm. So the answer here is it's dark and similar to fat. So the next question we have to ask is there a mature or no periosteal reaction, or is there an immature and young periosteal reaction? So as we look at the bone here, we can see there's no real periosteal reaction. There's neither a mature nor immature reaction. It seems to be inert and not involving the bone. That's going to take us to the top of this algorithm. The next question we have to ask is about the calcium again. Is there calcium deposition within the lesion itself or not? So as we look back at this, we have a dark lesion similar to fat. We have no involvement of the bone, and when you look carefully, we don't really see any calcification. Of course, it can always be hidden by the bone, and so you would want an orthogonal view at least to confirm that, but for argument's sake, let's just assume there's no calcium within this lesion. So now that we have no calcium, we need to know, is this in a major extremity or the trunk, or is this in a small digit in the hand and foot? Well, it's a forearm. It's not in the hand, it's not in the foot, so we've now got a major extremity. So when we get to that, we now have our differential diagnosis. This is a fatty tumor of some sort. It's a lipoma, an atypical lipomatous tumor, or a lipoblastoma. Lipoblastomas are almost exclusively seen in children, so we know this is a mature patient, so we know it's at least a lipoma or atypical lipomatous tumor, and that's where histologic diagnosis and even genetic analysis with the MDM2 amplification comes in to get your actual diagnosis. But just using this X-ray alone, we can at least determine that this is one of two things, and there are many other things that it is probably not. Could this be a cystic lesion? Of course, and so that's why, again, these aren't hard and fast, these aren't perfect algorithms, but they are generalities. Case number 2, so now we've got a soft tissue mass, and again, the arrow sign is pointing to it. We do have orthogonal views on this one that confirm that it's kind of outside the bone, no obvious bone involvement. So again, we're going to go to the soft tissue X-ray. So the first question, again, we have to answer is it dark and similar to fat, or is it intermediate and similar to skeletal muscle? When you look at the quality of this lesion, irrespective of those calcium beads that are within the lesion, we can say, looking up at the thigh there, you can see what the intermediate gray of the musculature looks like compared to the subcutaneous fat, and I would say this looks more like the musculature than the fat. So we've got an intermediate signal similar to muscle. So the next question we have to ask is there a mature or no periosteal reaction, or is there an immature periosteal reaction? As we again look here on both orthogonal views, there's no obvious periosteal reaction at all, suggesting either a invisible margin or no involvement of the bone. So as we get back, we now are at the mature or no periosteal reaction. The next question we ask is there calcium or no calcium? And that can shoot us even all the way back to the upper part of this particular algorithm. As we just mentioned before, there are a few small deposits of calcium within this lesion, and the blue arrow is pointing to those on the left image. So once we know there's calcium, we're now either at the top or the bottom of this. If we're at the bottom, we're already at some sort of soft tissue sarcoma. Typically, liposarcoma, synovial sarcoma, and soft tissue osteosarcoma are the ones that will have calcium deposition with no obvious bone involvement. However, we don't have an MRI that confirms there's no bone involvement, which is why we may be up at the top. So if we look at the calcium up top, we now have to answer that question. So this could be one of those sarcomas we just mentioned. So if we're going to answer these top questions, then we need to look at the calcium itself and characterize it. So when we look at this calcium, we have a few cloud-like nodules of calcium. They're not smooth and round like you would expect for a phlebolith. They're not wispy and feathery. It's not extensive, it's only a small part of this lesion, and it's certainly not arcs and rings of calcification similar to a chondroid tumor. So I would characterize this as minimal cloud-like calcification. So now the next thing we need to know is there a zonal phenomenon to that calcification, meaning does it progress from mature to immature as we go from peripheral to central, or is it just haphazardly located and at various stages of development? Again, when we go back and look at the calcium, obviously we're not zooming in here, but you can see there's no real zonal phenomenon like you would see in heterotopic ossification, where you have a big ball of what looks like a bone with a cortex at the periphery and not much centrally. So you just have this cloud-like calcification that's deposited randomly. So we're now at the haphazard, which again lands us with the same exact answer, which is a soft tissue osteogenic sarcoma, a liposarcoma, or a synovial sarcoma most commonly. Again, it could be another soft tissue sarcoma that has calcium deposition, but I just put those ones in here because they're the most common. So again, whether you went to the top of this algorithm or not, you can come up with the same answer depending on how you characterize that calcium. And so this was a synovial sarcoma in a younger patient. Now we'll move on to the next case. So here's an x-ray of a wrist of a skeletally mature individual that shows a very large bone lesion in the distal radius. So we've now got a bone lesion, not a soft tissue lesion, and so we're going to go down the bone algorithms, and we can see that this is predominantly lytic. So we're going to use the lytic bone algorithm. So the first question we have to answer on that is, where is this located? Is it diaphyseal or is it metaphyseal or epiphyseal? Well, it's obviously metaphyseal and juxtaphyseal, so we're going to go down the metaphyseal pathway. So the next question we have to ask is there a sclerotic border on this or no sclerotic border? As we go back, we do see the expanded cortex, but don't confuse that for a sclerotic border, because as we look at the medullary component, there isn't really a sclerotic border down there as we approach the metadiaphyseal region of this bone. So we're going to say that there's no sclerotic border to this. So the next question is, do we have a child or an adult? Well, we just mentioned before, we've got open growth plates there in the distal radius and ulna, so we have a child. So once we have a child, we need to know, does this lesion cross the physis or not? And again, we can see it's juxtaphyseal, it goes right up to it, but there does not appear to be direct involvement of the physis itself or the epiphysis on these x-rays. So we're going to go with does not cross the physis. So the next thing we have to ask is, what does this bone look like? Has it expanded to be wider than the adjacent physis, or has it expanded but it is not wider than the adjacent physis? Again, when we look at this expansion, it's significantly wider in both planes compared to the distal physeal plate there in the radius. So this is wider than the adjacent physis. This is an aneurysmal bone cyst. Case number 4, we've got another bone lesion here. We can see this calcium deposition just outside the bone, but it is involving the bony cortex. So we're going to go down the blastic bone lesion here. We don't see any frank lysis within the bone, so we're not going to go with a mixed lesion here. We're going to go with a blastic lesion. So once we know it's blastic, the first question is, where is it located, or is there cortical destruction? So is this intramedullary, extramedullary, or is there just cortical destruction, meaning that basically it's both? So as we again take a look at this, we can see the cortex seems to be preserved there on the anterior margin of the femur. You can see that thick white line and this lesion sort of stuck on the surface of the bone. So we're going to say this is an extramedullary lesion. It's not obviously intramedullary. There's not obvious cortical destruction. So we're going to go with extramedullary. So the next question we have to ask ourselves is, where is it located? Is it diaphyseal or is it metaphyseal and epiphyseal? Well, it's right at that proximal taper as we go up into the greater trochanter. So this would be characterized as metaphyseal, not directly diaphyseal, although it does extend into that subtrochanteric region and starts to approach diaphyseal. That's not the predominant location of this tumor. So we're going to go with metaphyseal and epiphyseal. So the next question we have to know is there corticomedullary continuity or not? Does the cortex go out into this lesion and incorporate it, or is the cortex separate from this lesion? Well, you can see with this purple line, I've outlined where the cortex has been preserved compared to this lesion. So there does not appear to be corticomedullary continuity. The cortex does not go out into the lesion. So we've got no corticomedullary continuity. So the next thing we need to know about this calcium deposition is, would we characterize it as dense or cloud-like? Well, when you look at this, you can see the inferior part is dense, but the superior part is cloud-like. So you always go with the least when it comes to this, because cloud-like is what it's doing. The inferior portion that gets more dense usually is more a function of time. What we're talking about is it's equally dense throughout the entire lesion, which this is not. So this is a cloud-like type of blastic reaction. So what do we have? We have a periosteal osteosarcoma. So we have a stuck-on lesion on the surface of the bone with cloud-like ossification and osteoid production with no frank destruction or obvious intramedullary involvement, and that is usually going to be a periosteal osteosarcoma. Here's our next bone lesion. So now we can see this is within the bone. We can see there's certainly a lytic component to this, but there's also a blastic component to it. So I would characterize this as a mixed lesion where you have some extra calcium within the lesion and it's not just purely, frankly, lytic, but there's also that lytic component that's definitely there. So now we're going to go with the mixed algorithm. So the next question we ask is the same as the blastic, is basically, is there cortical involvement or not? So as we look here, we can see that there is cortical involvement inferiorly, and it's tough to project on this screen, but you'll have to take my word for it. The cortex is preserved there, and it is on the bottom of the femoral neck. But you can see where it is there that you lose a little bit of that head-neck junction. It flattens out a little bit. So you do have a little bit of some cortical expansion here, even though it's very subtle and minimal, but it seems to be there. It's not quite as much of a gouge between the head and the neck as you see superolaterally there. So we're going to go with cortical expansion on this one. Here you can see with all these arrows, the white arrows showing where it crosses over with some of the other ones. So we could end up anywhere here. So we've got a lot of questions to ask here. Do we have a sclerotic rim? Do we have vertical trabecular jail bars or wheel spokes? Do we have fusiform cortical thickening, or do we have cloud-like intralesional osteoid? So as we go back to this, we do have that blastic component, but I would not characterize it as that fluffy cloud-like osteoid that we just saw in the periosteal osteosarcoma. There's certainly not fusiform thickening of the cortex. If anything, the cortex is thinned here. We can maybe talk ourselves into there being a sclerotic rim here, but it's not the characteristic soap bubble appearance inside the lesion itself. So what we have here are these vertical lines of trabeculation in there that we would call jail bars. So as we go to the vertical trabecular jail bars or wheel spokes sometimes, where they're not all vertical, there's a central location that they all sunburst out of. This is an intraosseous hemangioma. So again, had we had that characteristic soap bubble appearance with the lobular bone lysis, we would have a non-ossifying fibroma or a chondromyxoid fibroma. If we had cortical thickening, it would lead us towards an osteoma or an osteoid osteoma. And if we had intralesional osteoid, we might be talking about an osteoblastoma. But because we don't really have those things, obviously, we've got an intraosseous hemangioma, and that's what this case was. Now we're going to move on to the MRI. So here we have a T1 in the bottom left, we have a fat-saturated T2 in the upper portion, and a fat-saturated T1 with contrast in the bottom right. So you can see this intramuscular lesion that's got a low signal intensity on T1, very bright homogeneous and signal intensity on T2 without much of a reactive zone. And on the post-contrast imaging, there is some peripheral enhancement, but there is some intralesional enhancement with a lot of contrast void within the lesion as well. So as we go to our MRI, we know we're in the soft tissue, we're not in the bone, so we've got to use that. So we've got to then look at the border. Is there an infiltrative border, a discrete border, or no obvious delineation between the lesion itself and the surrounding tissue? Well, when we look at this, we've got a nice round ball there. So I would argue that this has very discrete borders without a feathery and infiltrative appearance. So once we have a discrete border, we have to say, is there a reactive zone or no reactive zone? And you can see, again, this crosses over. So there can be lesions that sometimes have a reactive zone and sometimes don't. And so that's the important part here where you can have some crossover. But when we looked and we just mentioned, there's no real reactive zone around this. We don't see edema. We don't see an infiltrative inflammatory infiltrate. We don't see swelling, anything like that. So we've got discrete borders with no real reactive zone. So the next question we have to ask is what's going on with that contrast? Does it go intralesionally? Is it peripheral? Is it diffuse? Is it variable? And so as we just talked about, there is a little bit of peripheral, but there is definitely central. And that's what the purple arrow is pointing to, is that intralesional enhancement. And you can see the blue arrow there is pointing to the contrast void. So what we have is intralesional enhancement with some voids. So the next thing we have to ask is there a string or target sign? Well, usually you need a longitudinal cut, either a sagittal or a coronal view, to see that. And let's just assume that we had that here. We flipped through those images and we do not see a string sign. The target sign you will see on the axial cuts, where on the contrast you'll have what looks like a bullseye of no contrast enhancement centrally and maybe a few other speckles, but a lot of very bright intralesional enhancement. And this does not have that. This is much more infiltrative in terms of its enhancement pattern. Is the lesion homogeneous and very bright on the T2, or is it mixed bright and dark signal on the T2? Well, when we go back and look at that T2 fat saturated image up top, it's very homogeneous and it's very bright. It's as bright as any fluid on this sequence. So we're going to go with homogeneous, very bright on T2. So what we have is an intramuscular myxoma. And that's indeed what this case was. Now the next case, we've got a soft tissue mass and an MRI. Again, the T1 in the bottom left, the fat-saturated T2 up top, and the fat-saturated T1 post-contrast down low. So you can see this lesion in the dorsal aspect of the spine and into the soft tissues, but involving a portion of the trapezius muscle as well. So now we know we've got a soft tissue MRI and we've got to use the correct algorithm. So again, we want to characterize the border. Is it feathery and infiltrative? Is there no clear border, or is there a very discrete border? Well, when you look at this, you first want to jump to it and say, hey, there's a discrete border here because I can see the lesion obviously compared to the surrounding tissue. But what I've pointed to are the blue areas there where you have the feathery portion of the border that sort of blends out into the soft tissues there and starts bleeding out and running out there. So this would be characterized as a feathery and infiltrative border as opposed to that nice round discrete border with no feathery component to it like we just saw with that myxoma. So the next thing we have to ask is this deep and intramuscular, or is this superficial? And again, you can see this in the subcutaneous fat, so that where a lot of people will go wrong on this is they're going to say this is superficial, but if you look closely, that's what the blue arrow is pointing to here, is the trapezius muscle. So this is an intramuscular tumor. This would technically be characterized as deep. So now that we've defined this as a feathery infiltrative border with a deep intramuscular component, we need to know a little bit about that enhancement. Do we have intralesional enhancement? Do we have a haphazard or wispy enhancement with regions of contrast void, very similar to what we just saw with that myxoma? Or do we have a pure peripheral enhancement with no intralesional enhancement? Well, when we look at that bottom right component, we have very bright intralesional enhancement and pretty homogeneous throughout. There's only some very small linear voids that probably represent residual muscle tissue and not an actual tumorous contrast void. So we can say here that we've got very bright intralesional enhancement. And so that leads us to desmoid. That's the only thing usually that will have this kind of growth pattern and intralesional enhancement pattern. So this is an aggressive fibromatosis, and indeed that's what this case was. Next case, again, we've got an MRI with a lesion just lateral to the hip. We've got the T1 in the bottom left, the T2 up top, and the fat-saturated T1 with contrast on the bottom right. And so we have to ask ourselves the same questions. So as we're going into that soft tissue MRI, is there a very discrete border to this lesion? Is there a feathery and infiltrative border, or is there no clear delineation between the normal tissue and the lesion itself? When you look at the T1 and the T2, I would argue there's no real clear delineation between the lesion itself and the actual tissue that's there. There's no obvious discrete mass here. Yes, when you look at the contrast, you have that huge area of void that makes it look like there's a mass, but when you look at the T1 and the T2, there's nothing obvious. So we're going to go to infiltrative with no clear borders. It is going to be one of these diagnoses. It's either a hematoma within the muscle, diabetic myonecrosis, or a reactive process that's occurring, usually due to trauma or something like that. And this was a patient that had a diabetic myonecrosis. They were hospitalized for DKA with sugars in the 600s upon admission. And about 3 days into their hospital stay, they developed severe pain in that hip. And imaging workup was done when we were consulted, and that's what this is diabetic myonecrosis. This is not a sarcoma or a tumor. And so you have to be able to see that and see that difference between what a discrete tumor looks like compared to an infiltrative process within the native anatomy. So now we're going to move on to the bony MRI. So here we have a lesion in the distal femur. You can see open growth plates on this. Again, we have a T1 on the left, a T2 in the middle, and the post-contrast T1 on the right. So we're now in the MRI of bone. So the first question we have to ask is there marrow replacement or marrow preservation? So let's go back to that image. And as we look at this, you can see the blue arrow is pointing to the lesion and the purple arrow is pointing to the marrow. And so you can see that there's marrow preservation of the epiphysis, maybe some reactive edema there because you can see a bright signal on the T2 and even intralesional enhancement and on the post-contrast of that brighter signal. But you can see on the T1, there's still preservation of trabeculation and fat within that area that leads you more towards edema rather than tumor. But when you're in the metaphyseal region, you can see no preservation of fat and marrow within that lesion and complete replacement. So we're going to go with this has marrow replacement. So the next thing we need to know is there a black border to it, meaning usually a thick sclerotic border, or is there intralesional black signal, again, usually meaning dense calcium deposition, or is there no obvious sclerotic border? So when we go back to this, we're looking for a thick black border to this lesion on any of those sequences, and there's not an obvious one. So we're going to go with no sclerotic border. So the next thing we need to know is this comprised of multiple discrete lesions? So there are several marrow replacing lesions with interspersed normal marrow, or is this a single confluent lesion? When we look back at this, we don't see multiple peppered lesions around the bone marrow here, so what we have is one large discrete lesion. So once we have a single confluent lesion, we need to know, is it completely contained in intramedullary? Is there a soft tissue mass? And if so, is it circumferential around the entire bone? Or is it eccentric and only coming out one part of the bone in one direction? As we look here, we can see the soft tissue mass component that the blue arrows are pointing to. It's very obvious on the T2 and the contrast image, maybe not so obvious on the T1, but it's definitely there. And you can see it's eccentric. We don't see much of a soft tissue mass on the lateral portion here. And if we had an axial cut, we would confirm that as well. So here we have an eccentric soft tissue mass, single confluent lesion with no sclerotic border and replacement of the bone marrow. We have an osteogenic sarcoma. And indeed, that's what this was an osteoblastic osteosarcoma in a teenage child. Next case is basically a combination of two cases to highlight the subtle differences between these two lesions that are otherwise similar. So in the bottom left there, we have one case, and in the upper right, we have another case. All we have here are T1s and T2s. We don't have the post-contrast imaging for these particular cases, but it's really unnecessary to get the answer here. So let's go through each of these and answer this question. So we have the MRI, we have a bone, and what do we have? Do we have marrow preservation or marrow replacement? Well, let's look closely. So as we can see here on the T1, again, that's what you're looking at, and the fat-saturated T2, well, the T1 is best for determining marrow replacement. So you can see this lesion very intensely in the bottom left on the T2, but on the T1, there's still preservation of marrow fat within there. So it's not a replacing lesion. It has not replaced the marrow. It's preserving the marrow, it's just sort of infiltrating within it. So we have a non-marrow replacing lesion. Now in the upper one, you can see the changes in the marrow there. So the first thing we might jump to is we have a marrow replacing lesion. But what I've highlighted here with the blue arrows there is fat on the T1 that suppresses on the T2, that confirms marrow fat. There is still peppered marrow fat throughout this lesion. So yes, there may be a marrow replacing component of this, but there's also a marrow sparing component of this. So this is where it gets a little bit cloudy, and you've got to be able to see this and see the difference between this and the complete marrow replacement that we saw with that osteosarcoma. So now we're going to go on the marrow preservation algorithm. So the next thing we have to say is, do we have a feathery and infiltrative marrow signal? Is there a discrete abnormal marrow signal, or is there normal marrow with corticomedullary continuity of the lesion? So we don't have normal marrow here. We definitely have something abnormal, but that's preserving it, but slightly differently in both, where you have an infiltrative process, you have preservation of marrow peppered throughout both lesions, but the T1 is really where they are starkly different here. And so when we answer that question, we're going to say that they both have sort of a feathery and infiltrative marrow signal, and that's best seen really on the T2, where you could maybe argue there's discrete borders because there's an obvious change from normal marrow to not normal marrow, but you can see it's sort of infiltrative. It's not a rounded off, flattened surface. It just sort of fuzzes out and bleeds out and blends in with the marrow as it becomes more normal. So this is going to be a feathery and infiltrative marrow signal for both of these processes. So again, the next question, we have to just look at the T1 and say, do we have a minimal change or a significant change? In the bottom left on the T1, I would say we have a minimal change there. Yeah, there's a little bit of a graying, especially as you approach the joint surface, but overall the marrow is pretty well preserved there. I would say the marrow change in the upper right is much more extensive and obvious. So we do have minimal change in the bottom left. We do have significant change in the top right. And those are going to be two different things. And so what we have here is bone edema in the bottom left, which could be traumatic. It could be due to arthritis. It could be any number of things. And then in the upper right, we have red marrow conversion, which again is usually seen in the presence of hypoxia. So if it's idiopathic, especially if it's all over the place and in an adult, it would be normal for a child. But if you see it in an adult, then you might need to work this patient up for either sickle cell trait or anemia, smoking, some other problem that's leading to chronic hypoxia in them while they're getting red marrow conversion back. So that's the end of this particular presentation. I'll leave you with my Pacific Northwest Pride slide. This is a view of Crater Lake, and this has not been doctored. That is how blue that lake is. It really is an amazing sight. It's about 4 hours or so from Corvallis, and there's camping there and even a hiking path that does go all the way down to the water where you can actually swim if you want, if you ever get a chance when you're in Oregon. So thanks again for listening. Hopefully these algorithms are helpful and can help you use your tools a little bit better to figure out a differential or actual diagnosis, depending on where you end up in the algorithm. But hopefully these will just help out. But again, don't take it all to heart, because there are areas where this has some shortcomings, or you may not have a classic presentation, so you might get the answer wrong. But again, it's just a general tool that will hopefully help.